don't know if we have the social workers in here who just led our groups. Are they in the hall? Could someone back there maybe just, we have one, but could someone back there maybe just ask people to come in while we get started? Okay, well, I wanted to thank the social workers. We'll have to thank them again. I hope the breakout sessions were helpful for you all. I know that they're always really helpful for me, and I think having them tomorrow too is a really big gift and blessing that our volunteers are giving to us. So maybe we could just give a round of applause to the leaders of the breakout sessions. So now we're going to switch gears a little bit, and the title of the session 3 that we're in this afternoon is What Can Be Done Once My Cancer Has Spread? So we are starting this out with a session on managing liver metastases, and we are really lucky to have 3 of the top people in the field who are treating liver metastases right now here with us. 2 are from Jefferson Cancer Center, and 1, Dr. Pinpank, is from the University of Pittsburgh, and we're just really grateful to the 3 of you for being here today. And I think we're going to start with Dr. David Eschelman, and then Dr. Carin Gosalves will go second, and Dr. James Pinpank will speak third. And then we'll have time for questions and answers, and I think the 3 of you will be here for the Q&A session at the end too, if there are additional questions. So I'll give it over to Dr. Eschelman.
Thank you, Sarah. We want to welcome all of you here to Jefferson, and we certainly want to thank the Melanoma Research Foundation for sponsoring this patient symposium. I received one recent request. Renee, she just stood up. Okay. That makes it easier. And then she sits down, and then she stands up. There was a request as to who is this Renee person? Now you know. Okay.
Can we turn down the lights?
Just as Sarah said, I'm joined by my dear friend and colleague, Carin Gosalves, and Jim Pinpank from the University of Pittsburgh for this session. While it'll be up to Sarah whether or not this ends at 3:45 as scheduled or 4 o'clock, it is our intent that we're going to be talking for 30 to 40 minutes, and the balance of the time is intended for questions, so we're not going to be talking for this whole time. So, from the disclosure standpoint, probably all of us will be discussing uses of products that are not approved by the FDA. That is common practice among physicians to use products outside of the FDA scope. It is mandatory in the field of interventional radiology. I happen to be a consultant for Gervais. They make an oily contrast agent named Lepiodol, which is routinely used as a delivery vehicle for chemoembolization and immunoembolization. And they're kindly helping to pay for dinner tonight. So, Jim is a surgical oncologist, so that makes sense. He's a surgeon. He specializes in treating patients with cancer. What exactly is an interventional radiologist? The field of radiology, diagnostic radiology, are the physicians specially trained to interpret, to read CT scans and MRI scans and ultrasounds and chest x-rays and those sorts of things. Interventional radiology is a subset of radiology where we perform surgical type procedures under x-ray guidance, usually x-ray guidance, sometimes ultrasound or CT, through tiny incisions. And the role Carin and I play in the treatment of patients with this disease is getting catheters, tiny plastic tubes, barely larger than a millimeter, out into the arteries supplying the liver and injecting things into the liver to try to kill these tumors. Why? Without trying to sound like an advertisement, why did Melanoma Research Foundation select Jefferson for this inaugural event? And many in the audience have met Carol and Jerry Shields, who spoke earlier this morning, and There are some familiar faces here who have met Takami, Carin, and myself, and we've become a national referral center for patients with metastatic uveal melanoma. 3/4 of the patients we see live outside of our tri-state area. And our practice and approach is rather unique in that we have a weekly multidisciplinary conference just dedicated solely to this patients with this disease, with Takami, a medical oncologist, Carin and myself as interventional radiologists, a body MRI specialist, and oftentimes a radiation oncologist is often there. We have a weekly multidisciplinary clinic that's, again, just dedicated to patients with this very rare disease. We're performing about 400 liver embolization procedures per year on patients just with metastatic uveal melanoma, and as you could calculate from the slide that either Carol or Jerry put up this morning, that about 1/4 of the patient's primary tumors are treated a block down the street here at Wills, which is a Jefferson affiliate. So, just to sort of add some perspective from the diagnosis of the primary tumor, these are 5 and 10-year approximate survival rates of 70% and 60% because almost half of patients will at some time in their disease course develop metastases or spread a tumor elsewhere in the liver. There's an often quoted article from 20 years ago which highlighted the really dismal prognosis for patients with this disease once it metastasizes. Thankfully, we're doing better today. Not well enough, but this is why the 3 of us and Takami, the 4 of us, come to work every day, because we're trying to do better and enable patients to live even longer. But as many of you know, this can be a very horribly aggressive disease. This is an MRI of a patient's abdomen, and this big white thing is the liver. The unfortunate thing is all these dark gray areas are tumors. And then therein lies the sobering fact that this was normal 6 months ago. Improved treatment of the primary tumor really has not resulted in prolonged survival, and the reality is that even though we can't see them, in many patients who eventually develop metastases, it's because those little tumor cells have gotten out prior to even the diagnosis of the primary tumor. There's a lot of interest in the genetics, which obviously Scott discussed this morning. Bill Harbour has done a lot of work in gene expression profiling and being able to look at a number of genes on the tumor to stratify patients into a very high risk of eventually developing metastases and a very low risk of developing metastases. And certainly patients in the class 2 group need to be followed much more closely, and those are the patients for whom consideration to potential adjuvant therapies will be directed. Why do we focus on the liver? The liver is the predominant organ of involvement in more than 90% of patients with metastases from this tumor. It tends to be the first, and in half of patients, the only manifestation of the disease. The tumors can also spread to lungs and bone and brain, or under the skin, or other sites in the body and the belly. But the course of patients with metastases is generally determined by the progression of disease in the liver. And this pattern of metastases is very different from patients with skin melanoma, where it generally goes to local lymph nodes, the lungs, and subcutaneous tissues. Unlike patients with skin melanoma, there's no effective systemic chemotherapy regimen for patients with metastatic uveal melanoma. And you've probably had friends or family members who've had lung cancer or breast cancer or something like that. If the disease spreads from the initial site, they get chemotherapy to go through their whole bodies to try to kill the tumors. Unfortunately, we don't have that yet for this disease. There's no proven adjuvant therapy for patients who are at high risk for developing metastases. So because the clinical course of most patients with MUM is based on the status of the disease in the liver, that's why we focus on loco-regional therapy, just treating the tumors in the liver to try to control the metastases. Surgical resection, ablation techniques are rarely useful because patients often have multiple tumors. And we've found that if the tumors show up in the liver within 5 years of the initial eye diagnosis, if those patients undergo surgical resection, meaning having part of the tumor cutting out, there's a very high rate of recurrence. This is a patient who was headed towards resection for what was presumed to be a solitary tumor, but little black dots on the surface of the liver, so that procedure was abandoned. There are a number of potential treatments directed at treating tumors in the liver, and this is what we're going to spend the next 45 minutes discussing. Carin is going to discuss radioactive microspheres and chemoembolization. Then Jim will discuss isolated hepatic perfusion and percutaneous hepatic perfusion, and then I'll follow up with immunoembolization. Photomustine infusion. This is a different chemotherapy agent. It is not approved for use in the United States. There are a couple trials from a number of years ago suggesting some promise as a therapy in Europe, infusing it into the liver under some various regimens. That's about as far as we're going to discuss it here because it's not available in the United States. So that being said, let me turn this over to Carin.
There it is. It should be. There we go. Let me just push that in a little. Okay, I'll just lower it around. Everybody knows I lower the table when I do my procedures too, so anyway. Okay, thank you everybody for being here. It's nice to see so many friendly faces, and you all look so well, and everybody's smiling, so I hope that today has been very productive, and it has been for us as well. I'll be discussing radioembolization and chemoembolization for the treatment of uveal melanoma, hepatic metastases. Can everybody hear me? You guys okay? Okay. All right, Dr. Eschelman already discussed this, but as the liver is the first site and often the only site of metastatic disease, local liver treatments such as radioembolization or chemoembolization, which is also known as TACE, has been used to control the growth of hepatic tumors and prolong survival for patients with uveal melanoma metastases. Now, radioembolization is defined as the injection of micron-sized particles loaded with a radioactive isotope directly into the hepatic artery to treat liver tumors. And the most commonly used radioactive isotope for radioembolization is known as yttrium-90. And Serspheres is the radioactive microsphere of choice for the treatment of uveal melanoma. This is just what they look like under electron microscopy. Okay, so how does Serspheres work? Well, the tumors obtain a majority of the blood flow from the hepatic artery, as you can see from the picture on the right-hand side of the screen. Therefore, injection of Serspheres into the hepatic artery destroys tumor cells by exposing them to high-dose radiation. In addition, Serspheres also block tumor blood flow, causing tumor ischemia or tumor cell death, which contributes to the effectiveness of radioembolization. Now, prior to a Sersphere treatment, arteriography is essential to prevent inadvertent delivery of Serspheres to non-target organs like the stomach, the pancreas, or the duodenum. Therefore, embolization or occlusion of arteries supplying the stomach or the duodenum or the pancreas, and sometimes even in some situations the skin, may be required to prevent injury to these structures prior to radioembolization. And this is just an example of what an arteriogram looks like. And you can see I have 2 hours here. There's one here and one here. One supplies, this is the left hepatic artery, this is the right hepatic artery. This is where you're going to place your catheter, put the radioactive microspheres. But if you look closely here, there's a little artery there. It's pretty hair-like in size. That is an artery supplying the stomach. And then this one here is supplying the the duodenum and the pancreas. You do not want to place radioactive microspheres into those vessels. So what you have to do prior to that is block off these arteries with these little metal coils that have these little fibers on them to divert flow just to the liver so that we protect the stomach and any non-target organs from the treatment. This is what happens if you get radioactive microspheres into the stomach. This is an endoscopic image of the stomach. This is an ulcer along the lesser curvature of the stomach due to radioactive microspheres getting into that vessel. And this is a biopsy of that ulcer. And you can see these are actually just little spheres sitting in the arteries. So this patient had a pretty significant ulceration from the procedure. Now, the incidence of GI ulceration is 5% in the literature, and I'm very proud to say that Dr. Eschelman and I have had no ulcerations in the last, I don't know how many years, Dave, since 2000, 5.5 years. He's very good with numbers. Okay. In addition, lung damage, radiation pneumonitis, can also occur due to shunting of spheres from the liver to the lungs. So we also perform nuclear medicine imaging to look for lung shunting on the same day as the pre-treatment arteriogram when we start coiling those vessels. If somebody has greater than 20% shunting of blood from the liver to the lungs, they are not candidates for radioembolization. And this is what a normal nuclear medicine scan would look like. There's just uptake in the liver, but none in the lungs. But over here, you can see there's uptake in the liver, but then here you see the right and left lung. So this patient is not a candidate for radioembolization. And this is what the box looks like. This is the sphere delivery box. It's really not that sophisticated. But this vial here is called a V vial, and in that is these sand-like little, it looks almost like sand. These are the radioactive microspheres, the spheres, and these are delivered through a tubing and through a catheter, which is in the right common femoral artery. You can see here better on the picture here, a catheter, which Dr. Eschelman already said is a hollow tube. It's threaded all the way into the liver, which into the hepatic artery, which supplies the tumors, and that's how we deliver the spheres. Okay, so how about results with radioactive microspheres? Well, there's not a heck of a lot out there. There's actually 3 articles. One just came out in 2012, but this one was in 2009 by Kennedy and others, and this was a retrospective study, and it was actually 5 different centers all over the world. So we obviously know this is a rare tumor. Only 11 patients were included in the study, but what was impressive was that they had a 100% response rate at 3 months, so it was encouraging, and a 1-year survival of 80%. So we looked at our experience and published it in 2011, and this was also a retrospective review, but we treated 32 patients with metastatic uveal melanoma, but it was more of salvage therapy. These patients already failed our treatments such as immunoembolization, which Dr. Eschelman will be discussing, and also chemoembolization. And we also divided patients into 3 groups based on pre-treatment tumor burden because we wanted to see if the response rate was going to be different. So we divided them to less than 25%, 25 to 50, and then greater than or equal to 50%. And what we found was that one patient had a complete response, meaning we couldn't find any tumor in the post-procedure imaging. A partial response also occurred in one patient. This means that the tumor shrunk by at least 30%. We found stable disease in 18 patients, so the tumor didn't grow or didn't shrink more than 20%, and 12 patients did have disease progression. We had a median survival of 10 months with a range of 1 to 29 months, and remember, these are already after patients failed other therapies, so the median survival is obviously much longer than that. And our progression-free survival for hepatic mets was 4.7 months with a range of 1 to 26.5 months. Now, we also found that, based on our tumor burdens, that the overall survival was significantly longer for those who had less tumor, so less than 25% at the time of treatment, compared to patients with greater than 25%. It was 10.5 versus 3.9 months, respectively. They also had a significantly longer progression-free survival, 6.4 versus 3 months, respectively. For patients who had a response, either complete or partial response or stable disease, they also had a significantly longer overall survival compared to patients who had disease progression, 14.7 versus 4.9 months, respectively. In addition, the same group of patients had a significantly longer progression-free survival compared to patients with disease progression, 7.9 versus 3.1 months. And as far as adverse events or toxicities, we had no major complications. We did have some self-limiting mild toxicities, meaning fatigue, indigestion, and abdominal discomfort. This is just an example of the patient who had a complete response. This is a left lobe and a right lobe tumor. This is her after treatment. Can't see any more tumor, and her survival was 27 months. This is a young man who had a tumor in his medial segment, and it looks a little bit smaller, but this was stable disease, and this patient had an overall survival of 29 months. And then this patient, unfortunately, had disease progression. It went from a tiny tumor in the right lobe to a very large tumor about 11 months after treatment. And we need to know why. Why does this happen? Why do some patients respond to therapy and other patients don't? We're doing the same exact thing for these patients. So this led us to start our new trial. It's a phase 2 Sato trial at Thomas Jefferson only. We started accruing patients in the fall of November 2011. Our goal is to have 48 patients enrolled in about a 2-year period. And the purpose of this is to investigate the efficacy and safety of Sato in a prospective manner. And we also want to determine which patient population benefits most from radioembolization, or maybe patients we shouldn't even be treating with radioembolization. So what we're doing is we're performing liver biopsies prior to therapy, and we're going to look for those genetic abnormalities that we know might be more aggressive, and we're going to compare them to the response rate. I think this is very important. We need this information, and there's a lot of studies out there right now that do not have this information. A lot of them are retrospective. We're also going to look at blood samples pre and post radioembolization to identify changes in serum cytokines to also see if we can compare that to treatment response. Okay, so let's move on to chemoembolization. Chemoembolization combines hepatic artery infusion of cytotoxic drugs with blockage of tumor blood flow. Theoretic advantages of TACE include higher drug concentrations within hepatic tumors, longer dwell times for therapeutic agents within the liver, less systemic toxicities, and ability to render the tumors ischemic. Now, there are no standard chemoembolization protocols for metastatic uveal melanoma, and there are no comparison clinical trials showing superiority of one drug over another. And you can just see here, I just listed a few of them that have been published in the literature. We tend to use cormustine or BCNU at our institution. This is a summary slide of a majority of the literature that's out there, which you could see. If you could fit this on one slide, you know that this is a rare disease. The median overall survivors do have a variable range of 5.2 all the way up to 21 months. But the one thing that you'll notice on this slide is that the overall survival for responders is significantly longer than those that don't respond to treatment. Now, that obviously makes sense. But again, why? Why do some people respond and others do not? This is just our results of our experience with BCNU chemoembolization published in 2005. I just wanted you to point out that in this study, it was 100 milligrams of BCNU. We now use 200 milligrams of BCNU, which I'll discuss in a couple of minutes. The median survival was only 5.2 months with a range of 0.1 to 27.6 months. But again, those who responded to treatment was 21.9 months compared to those who did not, only 3.3 months. In addition, again, less tumor burden. Patients did much better than patients with a significant tumor burden, especially here. I just want to point this out because greater than 50%, the median survival was 2.1 months. Okay, so if you have a lot of tumor, obviously your overall survival was less in this particular study. Okay, this is just an example of a patient pre and post chemoembolization. These are MRI images of the liver. You can see the tumors scattered throughout both left and right lobes. And then after treatment, this patient has stable disease, but these black holes are tumor necrosis. So chemoembolization had an effect on these tumors. And this is a patient who had a very large left lobe tumor and a right lobe tumor. This lady was actually told to go home and just die. She came to see us, and we treated her with BCNU chemoembolization. Follow-up showed a significantly decrease in size of both her tumors, but more importantly, on her MRI, she had no enhancement, and she's now on an 8-month treatment break. And I get nice letters from her. Okay, so what do we do for patients who present with large tumor burdens? This is unfortunately a common occurrence. This is very difficult for Dave and Takami on Monday afternoons or Monday mornings when we see this image. This is the liver. All this white stuff is tumor. Okay, so what do we do for these patients? Well, if they come in with good performance status and their LFTs are normal, we treat them. Okay, and so I went back recently and we looked at all our chemoembolization data on these patients who have this large tumor burden. Are we doing them, any service by treating them? And what we found was that The progression-free survival is 5 months, range of 1.1 to 32.3 months, but the median survival was 7.1 months, which, remember, if I pointed out, was 2.1 months with 100 milligrams of BCNU, with a range of 1.2 to 32.3 months. And then this, I thought, was, it's good. Obviously, it's not great, but 22% of patients survived greater than 1 year, with a median survival of 15.2 months and a range of 12.2 to 32.3 months. This is not published data, so this is hopefully will be published in the next interventional radiology journal. Okay, and this is that same lady who showed up with greater than 50% tumor burden. Again, all this white stuff is tumor. This is her 13 months later. Doesn't look much different. So she achieved stable disease and a lot more time with her family. Another patient, 8 months after treatment, pretty much stable disease. And this patient actually achieved partial response, but unfortunately, he passed away 14 and a half months after treatment because of brain metastases. In summary, radioembolization and chemoembolization are safe and effective treatments for metastatic uveal melanoma. Radioembolization we typically reserve for patients with less than 50% tumor burden due to the better overall and progression-free survivals that we have had in our experience. We do also use it for salvage therapy following failure of immunoembolization or chemoembolization. And we're hoping that our biopsy and our blood sample results from our phase 2 SERSFEAR trial may help determine which patient population is best suited for radioembolization. And as far as chemoembolization, we typically reserve this for patients who are not candidates for immunoembolization or radioembolization. Dr. Eschelman will probably go into that a little bit. And we also use it for salvage therapy following failure of alternative therapies and as first-line therapy for patients with large tumor burdens. This is just a picture of my two heroes. And Dr. Sato is one of the most modest people you will ever meet, but he's absolutely wonderful to work with, and I'm honored to work with him on a daily basis, or a minute-by-minute basis, it seems like. And thank you for your attention. You got to switch us back, sorry.
I need a mic. I've been told I don't need a mic ever. Where's the mouse? Okay. Well, I have to raise the mic up a little higher than Carin, but I'd like to thank Sarah for all her help in organizing this, and also congratulate the Jefferson Group on really what is many, many years of very fantastic results that have clearly benefited patients. In parallel with what they've been doing, we've been looking at some other agents which are in general quite toxic, but through ways of presenting directly to the liver, we feel are quite effective in managing patients with metastatic disease. In the form of disclosures, I personally have no conflicts. I will be talking about some off-label use of a drug and a device, and the multiple center trial that I'll be talking about used or was funded by the company Delcast Systems, so all the institutions which participated and received funding from it. That device or the delivery system is approved as a device in Europe and is under submission as a drug within the United States. So it is approved for use in Europe for any and all indications related to liver tumors, and right now it is under review for the management of metastatic melanoma within the United States, so somewhat different pathways. So the treatment, and we've talked about this a little bit, but the treatment of patients with metastatic disease to the liver really makes a lot of sense in this, and as surgeons, one of our interests in our group at Pittsburgh is looking at the management of patients with metastatic tumors to a variety of areas of the body, but really all contained within the abdomen. And for patients, as David has talked about, for patients who present, which one's the pointer here? Oh, there, okay. So for patients with metastatic tumors from ocular melanoma, approximately 50% of them will develop metastatic disease, which is predominant within the liver, which means targeting the liver in order to control the disease while holding off other therapies that would go systemically makes a lot of sense. Right now, we do not see any evidence that systemic chemotherapy or immunotherapy appear to alter the natural history of the disease. And as Carin has alluded to, the liver is different than a lot of other organs in that you can essentially completely isolate the inflow and outflow to the organ so that you can give all of your drug, hopefully, directly into the liver and none to the rest of the body. The other thing that's interesting is that there's a vein that goes into the liver that brings a lot of blood supply to the normal liver, but the tumors are supplied by the artery. So by accessing the artery as opposed to the vein, you're preferentially, even within the liver, targeting the therapy to the tumor cells and not the normal liver cells. The liver, although is very resistant to most drugs, and so the hepatocytes, unless they're very damaged by surrounding tumor, tolerate most therapies quite well. So why melphalan and what is melphalan? As my former boss at the NCI, Stephen Rosenberg, used to say, if you can get melphalan in the right dose anywhere in the body, it will kill whatever tumor you need to kill. It's a very non-specific drug. It incorporates into DNA, and when cells try and divide, the DNA is damaged, and so the cells cannot effectively divide. It's just like weed killer. The reason it doesn't kill your whole lawn is because you're trying to kill things that are dividing quicker. The things that grow more slowly are more resistant. The same thing is true with chemotherapies. The problem with melphalan is it is very toxic, and cells that divide very rapidly in the majority of your body are bone marrow cells and intestinal lining cells, stomach, small bowel, large bowel. So if you give this drug to the whole body, it hurts those cells at doses lower than you can get it to hurt the tumor cells. So we need to find a way to get it to the tumors and avoid cells that can be damaged. The two areas where melanoma is most relevant in the body are the extremity, either the arms and the legs, where there are no intestinal cells and no real significant bone marrow cells, and in the liver, where there are none of those cells as well. So if you can get the drug to those two areas of the body, control it, and keep it from going everywhere else, you can really use the benefits of dose escalating the drug to very, very high levels. The best studies that have been done overall look at patients who have had, or the longest term studies, are in patients with metastatic melanoma to the arms and legs, unable to be resected surgically because they had too much disease. And what you see when you treat patients with high doses of melphalan, which is dosed upon the size of the arm or the leg, that the response rates are approximately 9 out of 10 patients. And the median overall survival in these patients is 24 months. Interestingly, over a quarter of patients are alive at 5, and now we have data that say 10 years out from this. So patients who had an essentially fatal disease, but for reasons unknown to everyone really, failed to progress outside the local area of the body, were able to be controlled for very long periods of time. That was the reason that made us interested at the NCI in looking at this in the liver. It was another area of the body where metastases tend to go, where patients tend to die of the complications of local therapies and have significant symptoms related to local disease progression. And as it turns out, we were able to very much control the melphalan into and out of the liver. So this dose of melphalan, if we gave it to an IV, would, based upon your ideal body weight, would essentially wipe out your bone marrow and put you on a bone marrow transplant list. And in fact, in the pediatric population, that's what this drug is used. In patients who undergo bone marrow transplants, they're given a high dose of melphalan, wipes out the native blood cells, then you can give someone a bone marrow transplant. When we treated 29 patients with isolated liver-only ocular melanoma, our overall response rate was 62%, and the median overall survival was 12 months. So we thought something that had a very effective signal and something that we could very safely deliver to patients. When our group moved in many parts up to Pittsburgh, we simplified the process, so what was at that point an 8 to 10 hour operation with a 2 to 4 day stay in the ICU and a 14-day stay in the hospital became a 5 to 6 hour operation with a 7-day stay in the hospital. One of the things we were able to do was to use percutaneous catheters to access the arteries, access the veins. And so it still does require a surgical exploration, but we completely remove any blood vessels which may be leaving the liver, above the liver, and then all the blood vessels that Carin showed you on a schematic, we actually surgically get control of. So the liver, although none of these vessels are cut, is essentially on a heart-lung bypass machine. So all the blood going in, all the blood going out is controlled. We can concentrate chemotherapy into that blood, run it through the liver for 60 minutes. We control a lot of the environment in which the liver gets the drug, so the liver is warmed because we know that increases the amount of tumor or drug which gets uptaken by the tumors. And we change the pH or make these tumors acidotic because we know the drug works well. We can't do those things if we don't have control of the liver. Meanwhile, the normal circulation of the rest of the body is in fact just that, normal circulation. And after 60 minutes, all the blood that's running through this circuit, which is somewhere about 10 to 15% of the patient's blood, will then get dumped into a bucket literally, and we'll fill that with saline. And then we unclamp all those vessels, and the liver just comes right back on circuit, and so the blood from the rest of the body then fills the rest of the liver. The data that we have now expanded into the Pittsburgh group, and this is, again, Dr. Alexander's data, or all of our data from the NCI. We now have this, and we're getting ready to publish this for all the patients we treated after 2003 at the NCI and all the patients we subsequently treated at the University of Pittsburgh, which comes out to approximately 100 patients, and have shown that, in fact, these response rates are applicable across a much larger group of patients, and it's something we continue to offer patients. Just the one thing that as other people have pointed out, this is a patient of ours who we brought to the operating room, and whenever we take someone to the operating room, we tell them we will resect the disease if we can get all of it out. But this is what was imageable in the MRI, this black lesion right here. And these were the multiple other lesions which were seen, which were just too small for MRI. And unfortunately, that's the problem with ocular melanoma, is it's just poorly imaged, and patients present very late. And so when patients are resectable, there's ample data that shows that it's safe to do. In the probably 120 patients who we've explored operatively for this disease, we've completely resected one. So it's a very low rate that patients come to surgical resection of all their disease. So the problem with that therapy we have is really that, like anything else, it's good but not perfect, and patients tend to recur. And when the tumors recur, the majority of the tumors will recur within the liver. That operative procedure we showed you is quite a significant operation, and there's a little bit of stress on patients. So we had been working for many years with a company trying to develop a way to do this minimally invasively. And in fact, we've made a fair amount of progress. And instead of using holes in the vein, this is actually a balloon that has holes in the side, a catheter, so it goes up behind the liver. And so here's contrast in the two balloons and blood leaving the liver and getting completely controlled by this catheter. So it comes out of the catheter, gets run through two charcoal filters, and then returned to the patient. So it's not recirculating like we were doing before, but it's an infusion with filtration of anything that doesn't get picked up by the liver. And it's a complicated slide, but this is what we see, is that most patients, the leak of the drug is about 77% of drug gets filtered. So most patients will have some neutropenia or low white blood cell counts. Most patients will have some thrombocytopenia or low platelet counts, and some patients will have some decrease in their blood counts. These are all treatable. There's standard chemotherapy side effects, but it's different than the surgical procedure we saw where none of these things occurred. The flip side of it is it's a shorter procedure, but it has to be administered 4 times. So the overall length of stay in the hospital is slightly longer when you use this percutaneously, and certainly the cost is more significant. So right now we've been defaulting to the surgical procedure as the first therapy of choice. But this just is a lot of scientific data, but what I wanted to show you right here is this area of gray is the drug that's going into the liver, and this area in blue is the drug that escapes out into the systemic level. And so this is the benefit. You could not give all this gray area of concentrated drug into the whole body, and it would have too much side effects. But this differential is all the benefit of getting drug into the liver and not to the rest of the body. The way we treat patients is on study is every 4 to 5 weeks get treated. Our home with a performance status about 80% of baseline, so doing most activities you want to do. And every 4 to 5 weeks are treated with imaging after every 2 treatments. So following patients very, very closely. The majority of patients get 3 to 4 treatments before a treatment break. Let me just go through. So this is what we saw when we ran a trial. So in order to get this through the FDA, you have to run a randomized trial, which means patients enroll in the trial, randomly put into one of 2 treatment arms. And the 2 treatment arms we had were best alternative care. So what we and referring physicians felt was the best case for the patients to be treated with versus this experimental catheter-based system. And what we saw is when we looked at time differences in progression in the liver versus in the 2 treatment arms, we found that there was a very significant 8 months versus 1.6 month difference in progression in the liver. So patients who had the treatment had 4 times the amount of progression-free survival just within the liver that we had seen. Now these numbers, this number we wanted to be 0.05 or less, and this is substantially less. So this is what we consider to be a very significant response. Now, it doesn't do any good to treat the liver if the rest of the patient's not going to do well. And so one of the things we wanted to look at very, very closely was what happens in the rest of the body. Does controlling the liver impact on the rest of the body? And clearly, we've seen that that's true. Again, where patients had 6.7 months of overall body control, so there was a little bit of progression of disease outside the liver, versus 1.6 months in the treated arm with the experimental treatment or the liver-directed melphalan versus the non. We wrote this as a crossover trial, and the reason we did that was we felt it was unethical to withhold this therapy from patients based upon earlier data we had. So patients who progressed in the liver were allowed to cross over and then go on to get the experimental treatment after they had progressed in the liver. And what we saw is that there was an identical survival if you got the treatment as your first treatment or your second treatment. And that's actually very encouraging because it means that even as a second-line therapy, this drug is very effective. So for patients who have progressed on previous therapies, it doesn't mean that they're going to necessarily be resistant to this as a therapy. So what does it do? Again, these are not as high quality as Carin's, but this dark area in this picture is the liver, and these are melanomas. So that's a melanoma there, that's a melanoma there, and here you can see this large melanoma hanging down off of this patient's liver. After 7 months after treatment, this is actually the stomach, so this is the only residual melanoma we see here, and the rest of the liver is actually quite clear, and this large tumor that was hanging down here is just this little nubbin right here. And after 7 months, the patient went on to a treatment break. Ultimately, spinal disease was what was progressed in her and what became the problem. And if we just have the lights down a little bit, if that's possible. This is just one other patient who we had treated at Pittsburgh with very significant tumor in both sides. So this dark area is the liver. These big white spots are tumors in her, are tumors. We felt that this was a little more disease. She had been pretty beaten up by some other therapies, so we put her on this as opposed to giving her the open liver perfusion. And you can see almost complete clearing of the disease. There's a little shadow, which is hard to see, of a tumor that was negative on PET scan. And she did well for 12 months and then subsequently recurred in the liver, and we flipped it, and then we went and did an open liver perfusion on her. The drug worked again and had another 12-month response before we had to then deal with progressive disease. So I think that in conclusion, this is a drug and a system administered either way which work well and are tolerated well by a large majority of patients. Certainly patients who present with sick livers and very significant disease, depending on the approach, either greater than 50 or greater than 75% of their liver involved with tumor, can be hard to get them through therapy, but we have a pretty good scoring system that we think gets people through very safely. We clearly have shown that you can prolong the hepatic progression-free survival versus standard regimens. And so all this data right now is in front of the FDA for review, which hopefully in the next several months will result in this becoming a widely available therapy for patients. This was not done in isolation. This was started at the NCI and then maintained after the majority of us left by Mary Beth Hughes, Rich Alexander's at the University of Maryland. You can see multiple other institutions which were essential in getting 93 patients onto a relatively complicated trial. Thanks a lot.
Boy, that really makes Pittsburgh look beautiful.
It's one of those 3 months a year that
Yeah, I was going to say, I've been to Pittsburgh. It didn't look like that. I guess so. As patients began to survive longer with chemoembolization, there was an increased frequency of metastases outside of the liver. And that led to the development of immunoembolization here at Jefferson by Takami Sato, Kevin Sullivan, who's an interventional radiologist who was here for many years and we miss terribly, and Mike Mastrangelo, who's a highly regarded melanoma doctor. The goal of a cancer vaccine is to make the host immune system identify cancer cells as foreign and then target those cells for destruction. The challenge is that cancer cells are not foreign, and response to regular cells is tightly controlled. I'm going to skip over this in the interest of time. The hope is that if you can kill a tumor by embolization, meaning cutting off its blood supply, as Carin was discussing, that would hopefully control tumor progression locally and provide tumor antigens or little markers to the local immune system saying, hi, I'm here, I'm not supposed to be here, come and get me. And then if you simultaneously add an immunostimulant to induce an inflammatory response in the tumor and the surrounding tissue, may help improve that function of the body to recognize these cells as abnormal, and then stimulate the immune system locally, may result in development of a systemic immune response, meaning immune response throughout the body, which hopefully will suppress the growth of tumor cells and hopefully create an in situ tumor vaccine. Again, the three of us are sort of trying to take what are normally 30 or 45 or hour-long lectures and condensing them down into 10 or 15 minutes. So let me just jump to results of a phase 1 study for immunoembolization that we did, which again, immunoembolization is getting the tiny catheter out into the arteries in the liver and injecting, in this case, an immunologic stimulant, followed by blocking off the blood supply. A third of the patients responded, meaning their tumors either got smaller or went away. A third of the patients, the tumors stayed about the same size, with an overall survival of the entire group of 14 months. But the third of patients where the tumors got smaller were approaching 3 years of survival. Again, it's our goal. We're trying to keep making this longer and longer, but this is a far cry from what I showed you where we were 20 years ago. And also, these numbers are in the, we didn't have radioactive microspheres as an addition to our armamentarium when we were treating patients in this study. This is an example of a patient's hepatic arteriogram. This is the artery going to the right side of the liver, and these are big tumors in this patient. When he came back 2 months later, you see an absence of that dense black tumor vascularity, which is a lot of blood flow to the tumor. This is that same patient, just a later image during the same arteriogram, where again, before treatment, he had these big black tumors, and you just had these little residual rims after the first treatment. And again, this is largely due to the embolization effect, the blocking off of the blood supply effect. We found that in this study, in patients who had a higher dose, who received a higher dose of the immunologic stimulant, they had longer overall survival than similar patients who were previously treated at our institution with chemoembolization. So that's suggesting that this was conferring some benefit. While there was not a statistical difference in the time period that it took for tumors to grow inside the liver, patients who received immunoembolization, it took a longer time for tumors to develop outside of the liver than in patients who had been treated with chemoembolization. So that suggests that hopefully this immune response is working. So stabilization of the liver tumors is most likely achieved by cutting off the blood supply to the tumors rather than necessarily the administered medication. But again, since systemic progression was delayed in the high-dose immunoembolization group, that suggests induction of a systemic immune response. As an example, again, this is an MRI of a patient's liver, and this big white thing is the liver, these are kidneys. After 8 immunoembolization treatments, this patient did not have that much tumor to begin with. He had some relatively small tumors. We stopped treating him for 8 months. And over an 8-month period, remember the natural history of this thing, this is nasty, it's just going to grow. So to come back 8 months later with no treatment and have the tumors maybe a millimeter or 2 bigger is kind of remarkable. On his next set of scans 2 months later, the tumors were clearly a bit bigger, and we've restarted immunoembolization treatment to which he's responding very well. Unfortunately, as I said, not everyone responds to immunoembolization, and we don't yet know how to predict who will respond and who won't. And this is a patient whose tumors, look at these 4 dots, clearly grew in 2 months despite treatment, and that tumor also grew. Just briefly, a newer chemoembolization technique we're using over the past year and a half, 2 years or so, is a product called drug-eluting beads. Tiny, tiny beads that soak up chemotherapy, and then when they're injected into the arteries of the liver, the chemotherapy leaches out. Right now, there are only 2 chemotherapy agents that can be attached to these beads, that can be soaked up in these beads, and we've actually been doing a trial using one of those chemotherapeutic agents. They kind of look like little fish eggs, and the blue ones are irinotecan, the red ones Adriamycin. There was one small Italian study in a journal no one's ever heard of, which used irinotecan as the chemotherapy agent, showing remarkable responses. We did try to treat a few patients in this manner. We obviously failed by not choosing Italians. This is one of the patients on this trial, and he had just a few tumors. This was the main one. The beads did quite a number on the right lobe of the liver, which kind of shrunk down to next to nothing, but he has no active tumor more than a year out, actually approaching a year and a half out from treatment in this manner. A number of early patients develop myelomas or injuries to the bile ducts, and we've developed some techniques to try to minimize the chance of that happening, but we've had some impressive results. This is a lady who showed up with really huge tumors, and after starting her treatment, you see very little vascularity to those tumors. She's doing well almost a year down the road. This is someone who I just treated a couple months ago, but her 2 main initial tumors were this, and we've gotten pretty remarkable shrinkage from that. With that, we're just, when we see patients initially, and obviously there's a lot of variation based on a number of factors with the patients, but sort of in general, if they're not appropriate for having resection, having the tumor cut out, if they're not appropriate for us to send them to Jim Pinpank, if there's less than 50% liver involvement and limited disease outside of the liver, we'll usually offer patients either radioactive microspheres or immunoembolization. We don't yet know which one is better as an initial therapy. We're trying to sort that out as part of our SurSphere trial. If patients have over 50% liver involvement, we're looking at chemoembolization using one of the several methods discussed. And in general, if patients progress after immunoembolization, we're generally looking to either radioactive microspheres if they have relatively little tumor burden, or chemoembolization. It seemed like all of us were a little more long-winded than we anticipated. There is another question and answer session built into the program for later in the afternoon. So at that point, we're happy to take any questions for a few minutes. Thank you. Ted has a question.
Based on your slide, are you saying this kind of came up also when all the Mets people were talking earlier. Would you say that reading into the slide is that the first choice now is actually IHP and resection before immuno and SurSpheres and stuff, or?
Let me answer that a couple ways, and then I will also give Jim an opportunity to respond. As he alluded to, it is very, 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 very uncommon for a patient to be appropriate for resection, meaning they have 1 or 2 tumors in the same area of the liver and not lots of little dots. If we see someone with 1 known tumor more than 5 years out from the initial diagnosis of the eye tumor, surgical resection is absolutely a consideration. Maybe that happens once a year in our practice or less, okay? I think it is fair to say that most of the patients who end up seeing us on a Monday have pre-selected themselves to not be interested in IHP. If we feel it is appropriate, and we kind of know the patients that Jim is interested and able to treat by that method, we often mention that as an option, as a treatment option. In general, most of the people we see said, thank you, that sounds like a big operation, I'm not interested in that. So I think we have some selection bias as to who's showing up through our door. There certainly are some patients who, at other times of their disease course, we may say, I think we need to at least introduce this as a potential therapy. Okay? That is not something which we offer at Jefferson for a bunch of reasons, including the fact that there's someone really good 6 hours away, so I'm not sure that at this point that's something we need to be offering here. If you could just wait for the microphone, please.
I'm thinking about what's offered where. I hear, Pittsburgh and here. What about the West Coast? Are there people on the West Coast doing these types of procedures? Or do I have to fly out here? Metastasis.
Virgin has those new flights in the fancy planes, and we see the billboards. The tape is off, right? Okay. You're asking a very reasonable question. This is a big country. There are a lot of damn good medical centers across the country. For example, there are a number of very good people at Stanford who are quite good, who frequently perform chemoembolization procedures and have been quite active in radioactive microspheres and that sort of thing. While we're talking about liver-directed therapy, this is still a disease which does involve more than the liver, and the big difference at a center like ours, and please, I'm not trying to sound like an advertisement, I'm trying to answer your question in a way I honestly try to answer it, not honestly try, that I honestly answer it when we're asked this by patients is, in many other centers, they may never have seen a patient with ocular melanoma, or maybe they see 1 or 2 patients a year. Whereas, we see several new patients every week here, and we have a clearly established multidisciplinary approach. You're not coming in and seeing an oncologist who may not even know where the interventional radiologist lives or that sort of thing. And when we've had some patients over the years, for understandable reasons, try to go elsewhere for therapy, which once that we can't tell someone else how to do the procedure, we can't tell them what drugs to use, that sort of thing. And most patients who we've seen prefer to continue undergoing evaluation and therapy here, even though it's obviously a schlep to get here. But this is a very, very rare disease, and what many people have found is you go somewhere else and you're facing someone who may not have the answers or experience in dealing with these issues that you deserve. Obviously, there are other centers across the country. Scott is here from MD Anderson, where they also see a large volume of patients with metastatic uveal melanoma. I hope I answered that in a reasonable manner. I answered it in an honest manner. You're not all here because it's trying to be an advertisement for Jefferson. Please. Here.
You can get radioactive microspheres at a lot of institutions, okay? So, but as far as immunoembolization, pretty much we're the only institution that is doing that currently. The other thing is that most interventional radiologists are very used to using a 3-drug cocktail for any kind of tumor, whether it's, whether it's breast cancer, colon cancer, HCC, hepatocellular carcinoma, which is a primary tumor of the liver. Interventional radiologists do not have experience with BCNU, okay? And we have spoken to other interventional radiologists and told them how to do it, but I think to come to Jefferson, maybe not just see Dave and I, but to be treated by Dr. Sato, I think is vital to treating the whole person.
And there's a lady in the back with a question. She looks a little familiar.
Dave or Carin, I guess. Would you mind just commenting on the difference between theraspheres and the cerspheres?
Do we know where the other mic is?
Okay, so theraspheres, there's a lot of difference. I actually can give Sarah I have a lecture on radioembolization comparing the two. But theraspheres are FDA approved for primary tumors of the liver, for hepatocellular carcinoma, whereas cerspheres is approved for metastatic disease. And the reason being is that cerspheres, there are more of those microparticles in each dose, so it has an embolic effect. So we really feel that stopping the blood flow to tumor really impacts cell death and tumor death, and the theraspheres just don't have that embolic effect because they have less particles for each dose.